All right. Thank you very much, Florence, and good evening, senior colleagues and colleagues. So this evening, I'll be taking the topic Takotsubo Cardiomyopathy. So this will be the outline for my presentation. I hope my line is clear as well.
Yes, it's very clear.
Okay, thank you. So as a way of introduction, Takotsubo Cardiomyopathy is a syndrome that is characterized by a sudden transient cardiac syndrome that involves a dramatic left ventricular apical akinesis, and it usually mimics an acute coronary syndrome. But this happens in the absence of angiographic evidence of obstructive coronary artery disease or acute plaque rupture. In most cases of Takotsubo, the regional wall motion abnormality extends beyond the territory perfused by a single epicardial coronary artery. And this condition was first described in 5 Japanese patients in 1990 by Sato et al. And it has since been increasingly recognized around the world. It has other names such as stress cardiomyopathy, apical ballooning syndrome, broken heart syndrome, and stress-induced cardiomyopathy. And the term Takotsubo is taken from a Japanese name for an octopus trap or octopus spot, which has the shape of the octopus spot is similar to what we see in Takotsubo syndrome during systole. Mainly, we have the mid-ventricular type. The main one is the apical type, and we also have the mid-ventricular type, and then focal variants have also been described. And ballooning of the LV occurs most commonly at the apex in most cases, and this occurs in about 70 to 80% of the cases. And the mid-ventricular type occurs in about 10 to 20% of cases. So the picture inserted shows on the one labeled A, it's a ventriculogram of the LV in systole. So we can see that there is narrowing of the neck or the base of the LV with apical ballooning. And then the next image is an image of a Takotsubo, which is an octopus trap. So this looks very similar to Takotsubo cardiomyopathy. Okay, so the image, I've shown this already. So the image on the right of the screen shows the various variants of the Takotsubo cardiomyopathy. So on top, the first column is what we see in diastole. The second is how it shows in systole, and you have a cartoon image on the last row, on the last column. So the first row is a typical form, which is a apical type that shows apical ballooning. So we're looking at this column, the middle one. So this is what we see in systole. We have good contraction at the base with apical akinesis or hypokinesia. The next one is a mid-ventricular type, which involves the middle part or the midsection of the ventricle, sparing the base and then the apex. So if you look at the image during systole, there is good contractility at the base as well as the apex, but there is hypokinesis in the mid-ventricular region. And then we also have the basal type. The basal type, there is good contractility at the apex, but there is hypokinesis or akinesia at the base. And then the last type is a focal type, which can occur at any segment of the ventricle. So with the pathophysiology, with normal myocardium A normal myocardium utilizes approximately 90% of its energy from fatty acid metabolism at rest with anaerobic activity. And during ischemia, this pathway is suppressed and glucose is largely utilized instead. And this results in impaired cardiac function. So for patients with Takotsubo cardiomyopathy, they are found to have a shift towards the glucose pathway despite relatively normal myocardial perfusion and the lack of ischemia in the LV segment. The most commonly discussed possible mechanism for Takotsubo cardiomyopathy is stress-induced catecholamine release, resulting in catecholamine-induced microvascular spasm or microvascular dysfunction, and this results in myocardial stunning. An endocardial biopsy of patients with Takotsubo cardiomyopathy have demonstrated reversible focal myocytolysis and mononuclear infiltrate and contraction band necrosis. And the sympathetic or catecholamine theory is gaining momentum partly because it was induced in rats that were exposed to physical stress, and in some instances, the condition was prevented by treating the rats with alpha blockers and then beta blockers. Still on the pathophysiology, other evidence for the catecholamine theory has been demonstrated through myocardial imaging studies using catecholamine analogs that evaluated cardiac sympathetic activity. And cases of Takotsubo cardiomyopathy have been reported in literature following cocaine and methamphetamine and excessive phenylephrine usage. Studies have also found that patients with Takotsubo have higher levels of serum catecholamine, being either norepinephrine, epinephrine, or dopamine, than patients who present with myocardial infarction. The apical portion of the LV have the highest concentration of sympathetic innervation found in the heart, and this may explain why excess catecholamine seem to selectively affect the function of the LV apex. An underlying coronary endothelial dysfunction may also play a role in Takotsubo, wherein an abnormal tendency towards spasticity and in the coronary tree can manifest as angina and as Takotsubo cardiomyopathy. One theory indicates that substantially increased coronary spasticity may lead to diffuse transient spastic obliteration of the coronary arteries and to critical ischemia, which can be reproduced by acetylcholine testing early after an episode of Takotsubo cardiomyopathy. The cause of this condition is unknown, but several theories have been proposed and are under investigation. And these theories include multivessel coronary artery spasms, impaired cardiac microvascular function, impaired myocardial fatty acid metabolism, acute coronary syndrome with reperfusion injury, and endogenous catecholamine-induced myocardial stunning and microinfarction, and then underlying coronary endothelial dysfunction. So these are all proposed theories as the possible causes of Takotsubo cardiomyopathy, but the exact cause is unknown. However, there are several risk factors that have been attributed to Takotsubo cardiomyopathy, and a significant emotional or physical stress or neurologic injury typically precedes the development of Takotsubo cardiomyopathy. And these stresses include one, death of a loved one, bad financial news, legal issues, natural disasters like severe flood or earthquakes, and also motor vehicle collisions. This include exacerbation of a chronic illness, newly when patients are diagnosed with new medical conditions, patients going through major surgery, ICU stay, and the use or withdrawal of illicit drugs. So all these have been found to be potential risk factors for the development of Takotsubo cardiomyopathy. With its epidemiology, the International Takotsubo Registry reported that patients with Takotsubo cardiomyopathy, as compared with acute coronary syndrome patients, were more likely to be females. And usually about 90% of patients presenting with Takotsubo are females, except what is found in Japan, which is mainly found in males. And physical triggers were more common than emotional triggers in when only compared with ACS. And physical triggers usually occurs about 36% versus 27% in ACS. And nearly 90% of the reported cases, as mentioned earlier, are women, and usually these are women in their postmenopausal age. And it's been reported that the mean age for presentation in women is around 67 years. However, about a third of the cases have no clear triggers. And studies have reported 1.7 to 2.2% of patients who have had suspected ACS were actually diagnosed as having Takotsubo cardiomyopathy. Patients with this condition are usually of Asian descent or of white descent. And in literature review of cases in which races were reported, 57.2% were Asians, 40% were white, and about 2.8% were from other race. The actual incidence of Takotsubo is not known, but it's been found out that the incidents have been increasing since it was discovered in 1990 up to date. So how do these patients present? Usually they present just like acute coronary syndrome, and it's usually difficult to differentiate the two at the initial presentation. Commonly, they will present with chest pains, which is very common out of the presentations, occurring in about 75% of cases. They also present with dyspnea, syncope, palpitation, nausea, vomiting, and rarely do they present with cardiogenic shock. So basically, the presentation is very similar to that of acute coronary syndrome, and usually indistinguishable from that of patients with acute coronary syndrome. Okay, so the symptoms have been mentioned already. A unique feature of Takotsubo is its association with preceding emotional or physical stress trigger events. And unlike in ACS, for which the peak occurrence is during the morning hours, in Takotsubo events, it's usually presents in the afternoon when stressful triggers are more likely to take place. And in a large systemic review, found that patients with Takotsubo tend to have lower incidence of traditional cardiac risk factors such as hypertension, dyslipidemia, diabetes, smoking, or positive family history of a coronary vascular disease. Clinical findings are usually non-specific, or they may even have normal physical examination findings. However, patients may exhibit the clinical appearance of ACS or acute congestive heart failure. Patients usually may appear anxious and diaphoretic. They may have tachyarrhythmias. Some may also have arrhythmias. Hypotension can occur from reduction in stroke volume because of acute left ventricular systolic dysfunction or left ventricular arterial tract obstruction. Murmurs and crackles may present on auscultation in the setting of acute pulmonary edema. And these are some of the different diagnoses to Takotsubo cardiomyopathy. We have gastroesophageal reflux disease, myocardial infarction, myocarditis, acute pericarditis, pneumothorax, cardiogenic pulmonary edema, pulmonary embolism, unstable angina, and esophageal spasms. So we'll now look at how to investigate patients that we suspect as having Takotsubo cardiomyopathy. So one significant investigation modality is the ECG. It's been found out that in most cases of Takotsubo cardiomyopathy, they present with ST abnormalities. Typically, they present with ST elevation in the precordialis. Some also present with ST depressions or T-wave inversions. Chest X-ray is also very necessary. This helps pick up signs of pulmonary edema or cardiomegaly. Echocardiogram also plays an important role, as well as cardiac enzymes, BNP or NT-proBNP. For cardiac enzyme, it's been found that this is usually elevated modestly, but not as high as found in myocardial infarction. Coronary angiography and ventriculography also plays a vital role. So this is an ECG that is showing ST elevation, and this is actually an ECG from a patient that we managed back in 2022 for Takotsubo cardiomyopathy. And at the time he was 44 years, he's a 44-year-old male who presented with classic signs and symptoms of acute coronary syndrome, but the better diagnosis was Takotsubo cardiomyopathy. So ECG is a very important investigation tool that helps in the diagnosis of this condition. This also shows troponin that was done for him at the time. So he had elevated troponins, which was very high, about 33 times the upper limit. And troponin T was also elevated almost two times the upper limit. Echocardiogram is important because it helps in the estimation of left ventricular ejection fraction. And it's been found that patients with Takotsubo cardiomyopathy usually have an ejection fraction between 20 to 49%. Echo provides a quick method of diagnosing wall motion abnormalities, specifically hypokinesis or akinesis of the mid segment and apical segment of the left ventricle. These wall motion abnormalities extend beyond the distribution of any single coronary artery, as was mentioned earlier. Okay, so this is a typical echocardiogram image of Takotsubo cardiomyopathy. So if you look closely at the LV, we have good contractility at the base with barely any contraction at the apex with apical ballooning. Coronary angiogram is also very vital, and in most cases, almost all the cases, they usually have a normal coronary artery. However, we may find some non-significant obstruction in some cases, but by and large, most cases will present with a normal coronary angiogram. Okay, so this is a ventriculogram which can be done during coronary angiogram. So the first video shows a typical type of Takotsubo cardiomyopathy with apical ballooning. So you can see good contractility at the base, but poor contractility at the apex. The next video shows the mid-ventricular variant. So from this video, we can see that the base is contracting well, as well as the apex, sparing the middle section of the ventricle. So that's a mid-ventricular variant. Cardiac MRI can also facilitate the diagnosis of Takotsubo, and it accurately visualizes regional wall motion abnormalities. It's also good at quantifying LV function, and is able to identify reversible injury to the myocardium by the presence of edema, inflammation, and also the absence of necrosis or fibrosis. In addition, cardiac MRI has been found to differentiate Takotsubo, which is characterized by the absence of delayed gadolinium enhancement from MI or myocarditis. So usually in MI, there is delayed gadolinium enhancement, which is absent in Takotsubo cardiomyopathy. So this is a very key way of making a diagnosis of Takotsubo as against MI on MRI. Again, this is MRI of the patient I mentioned earlier, who we managed in 2022. So he had an EF of 30%. Okay, and mid to apical LV cavity edema and inflammation. And he also had a mid to apical LV wall enhancement, fibrosis, and fibrosis, but had no myocardial infarction or infiltration. And he also had apical LV thrombus. So we'll now look at the diagnostic criteria that is usually employed. So several institutions of medical research have produced clinical criteria that is useful in the diagnosis of Takotsubo. But there has not been a single consensus with this criteria. And one of the first set of guidelines was initially published in 2004 and was later revised in 2008 by the Mayo Clinic. And other research institutions proposing diagnostic criteria for Takotsubo include the Japanese Takotsubo Cardiomyopathy Study Group, the Takotsubo Italian Network in Heart Failure Associates, and Takotsubo Task Force of the European Society of Cardiology. So this is the revised criteria for Mayo Clinic for the diagnosis. So one, there has to be a transient dyskinesis of the LV mid segment, and there also has to be regional wall motion abnormality beyond a single epicardial vascular distribution. And there must also be absence of obstructive coronary artery disease or acute plaque rupture. And patients should also have new ECG abnormalities with modest troponin elevation. And of note is that there must be absence of pheochromocytoma or myocarditis. So with the management, Takotsubo is generally a transient disorder that is managed with supportive therapy, and conservative treatment and resolution of the physical or emotional stress usually results in rapid resolution of the symptoms. In patients who develop acute complications such as shock or acute heart failure will require intensive therapy. The appropriate management of shock varies based on whether there is LVOT obstruction or not. So complications are also quite common and occurs in about 20% of cases. And this particularly occurs in the early stage. And this includes left heart failure with or without pulmonary edema, cardiogenic shock, LVOT obstruction, mitral regurgitation, ventricular arrhythmias, LV thrombus, LV free wall rupture, and death. However, the death is quite rare. So for the heart failure, it's managed according to standard guideline recommendations. And this usually includes supplemental oxygen and assisted ventilation as and when required. It also will include intravenous diuretics to treat fluid overload if present. Dilated therapy as needed to correct elevated filling pressure and or LV afterload. However, volume depletion or vasodilator therapy should be avoided in patients with LVOT obstruction. And there are no specific randomized trial data to define an optimal medical regimen for Takotsubo cardiomyopathy. So usually, as said earlier, the management is conservative, but when there is heart failure, which in most cases will be heart failure with reduced ejection fraction, we follow the guidelines recommendations for heart failure. So recommendation for anticoagulation to prevent thromboembolism in patients with Takotsubo and LV thrombus or severe LV dysfunction are similar to those with patients who have post-myocardial infarction. And hemodynamically stable patients are treated with standard medication for HFrEF. And this usually include beta blocker therapy for patients without LVOT, for patients with LVOT obstruction. And for those without LVOT obstruction, ACE inhibitor, ARB, or diuretics are used when necessary. And observational data have suggested that acute use of beta blockers may not improve in-hospital mortality. And in a retrospective analysis of about 2,600 patients, 423 had beta blocker therapy initiated within the first 2 days. And this group did not show, didn't have any reduction in the 30-day in-hospital mortality. So for those who present with hypotension and shock, it's been found that approximately 5 to 10% of patients with Takotsubo may develop cardiogenic shock. And factors that are associated with the development of shock include young age and those who present with low ejection fraction, and also those who had physical triggers. And in-hospital mortality is almost 10 times higher in patients with shock as compared with those who present without shock. And again, in-hospital mortality from shock is lower in Takotsubo when compared with myocardial infarction. So since the management of shock differs depending upon whether LVOT is present or not, for patients who present with shock, it is recommended that echo is done urgently to determine whether or not LVOT is present. And in some cases, LVOT obstruction is accompanied with systolic anterior motion of the mitral valve and then mitral regurgitation. And this is similar to what is seen in hypertrophic cardiomyopathy. For those who have shock without LVOT obstruction, cautious fluid resuscitation for patients with hypotension without significant pulmonary edema is recommended. And patients with significant LVOT obstruction who have hypotension due to LV systolic dysfunction may require inotropic support. And with this, usually the vitamin or dopamine is recommended as a temporary measure to sustain the hemodynamics. And since Takotsubo is potentially caused by catecholamine excess, the impact of sympathomimetic remain to be established. And in patients with hypotension due to pump failure, inotropic agents may induce LVOT of obstruction, but the degree is usually mild. And inotropic therapy should be discontinued in patients who develop moderate to severe LVOT obstruction, and a change in the therapeutic approach is not recommended if the LVOT obstruction is just mild. Also, in patients with persistent hypotension with evidence of end organ hypoperfusion, despite optimization of the failing pressures and inotropic therapy, they may require the use of vasopressor therapy to cause peripheral vasoconstriction to increase the blood pressure. And mechanical circulatory support, such as intra-aortic balloon counterpulsation and percutaneous continuous flow devices, is the preferred therapy when there is marked LV dysfunction associated with severe hypotension or shock. So for those with hypotension and shock, and also LVOT obstruction, in contrast to hypotension due only to pump failure, hypotension associated with moderate to severe LVOT obstruction should not be treated with inotropic agents because this will worsen the degree of the obstruction. And moderate to severe LVOT obstruction is similar to that for patients with hypertrophic cardiomyopathy, obstruction, and hemodynamic collapse. And therapy includes the use of beta blockers, which can improve the hemodynamic by causing resolution of the obstruction. Again, in patients with LVOT obstruction and severe hypotension who either do not tolerate or do not respond adequately to beta blockers, an alpha agonist may be added with caution and with close monitoring. So phenylephrine is a pure alpha adrenergic agonist that may reduce the gradient by increasing afterload, thereby improving the overall hemodynamics. And in addition, in the absence of significant pulmonary edema, preload should be increased by leg elevation and fluid resuscitation. So the next complication is those who present with LV thrombus. So anticoagulation with vitamin K antagonists, usually warfarin, in the presence of LV thrombus is recommended. And the suggested duration of therapy is usually 3 months. However, the duration of anticoagulation may be modified based on the rate of recovery of the cardiac function and the resolution of the thrombus. So we don't, even though the recommended duration is about 3 months, there is not fixed. If at 3 months the cardiac function is still poor or the thrombus still persists, then the duration can be extended until these are resolved completely. For patients without thrombus, but with severe LV systolic dysfunction, that's EF of less than 30%, and have low bleeding risk, anticoagulation with warfarin is recommended until the akinesis or dyskinesis has resolved, or for 3 months, whichever will be shorter. So prognosis is typically excellent with nearly 95% complete recovery within 4 to 8 weeks. And in a study by Sine et al. Indicated that the annual recurrence rate is approximately 1.5%. And it also estimates an in-hospital mortality range between 1 to 3.2%. So in conclusion, and by way of summary, Takotsubo cardiomyopathy is a condition in which LV dilatation and acute systolic heart failure occurs, typically following emotional or physical stresses, and the pathophysiology is uncertain. However, evidence suggests a surge of stress-related hormone that contributes to apical ballooning via disruption in the microvascular or by myocardial toxicity. And worldwide, there is about 90% of cases that occur in postmenopausal women. However, in Japan, it's more common in men, and the men are more likely to develop Takotsubo following physical stress. And the common symptoms are chest pain, dyspnea, and dizziness. Physical findings may include lung rales, tachycardia, hypotension, narrow pulse pressure, and an injection systolic murmur, usually when there's an LVOT obstruction. ECG changes such as ST segment elevation or T wave inversion and cardiac are present, and also cardiac biomarkers are typically elevated. And treatment require inpatient care with cardiology service and is largely supportive until LV function spontaneously returns. So these are my references. So I'll end here and then we'll take comments, questions, or contributions.
Thank you so much, Dr. Eugene for that extensive presentation. We appreciate your efforts. Thank you. So the room is open to questions, open to contributions. Okay, so what's the natural cause of cardiomyopathy? Like any form of regression, like how long?
Hello.
Yeah, hello.
Hello. Yes. Can I please come again? It wasn't clear.
I said, what's the natural cause of Takotsubo cardiomyopathy? Like when the stressor is off, how long does it take for the person to get back to her normal state or a normal state?
Okay, so usually in theory, it's expected that usually between 4 to 8 weeks, the heart function would have most likely reverted to the normal or the premorbid state. But it's been observed that some will usually progress to about a year. And with the patient whose ECG I posted, for him, it took about 6 months for him to attain full recovery.
Okay, thank you so much. Thank you. Okay, so Dr. Conte, I can see your electronic hand. You can speak up, please.
Yes, thank you once more, Dr. Ofosu, for a very concise presentation. And on a lighter note, I like the way you pronounce the disease, like the Japanese Takotsubo. Florence, take note, that's the correct Japanese pronunciation.
Right. So I hope I don't bite my tongue. I'll try. Thank you.
And also, I really appreciate the the images. They are really, really very good images to depict, the condition, the ventriculogram, the echo images. Those are very good and will help us to remember. Thank you so much. I wanted to just comment on the evolution of the ECG changes in Takotsubo as compared to acute STEM.
Okay, so with that, what I came across was that usually they will present with ST elevation, and this will usually be in the precordial leads, and will later develop T-wave inversions, which may persist for a long period, sometimes even up to a year. And they may or may not have the development of Q waves. So mainly that's what I can say about the evolution.
Yes, you're right. So typically they do not develop Q waves. That's a typical pattern. And then there's some books will tell you that the ST elevation is not as marked as in as you would see in acute STEMI. So you don't have very marked ST elevation. And then, so after 48 hours, the ST elevation tends to come back to baseline, and then now followed by T-wave inversion. And then, as you said, the T-wave inversion can take months to resolve back to normal. Okay, thank you so much.
Okay, thank you very much for the contribution.
Okay, I can see Dr. Kitty Asamu has electronic hand up. Dr. Kitty, please speak up. Thank you.
Hi, good evening, everyone, and thank you very much, Ofosu, for the presentation. I just want to highlight or re-emphasize that diagnosing Takotsubo is usually a stepwise process. So it's not like you get a history and then you're done, or history and echo and you're done. But it starts as an ACS, and you follow the ACS algorithm, you get the angiogram done. Angiogram shows that there is no obstruction of the coronary arteries. When no obstruction, non-obstructive coronary arteries means that there's either an obstruction that is less than 50% or nothing at all, it's clean. Then from there, you go into a diagnosis of Minoka. And then from Minoka, you consider the differentials of Minoka, and to rule them out, then the MRI helps you and definitively diagnoses the Takotsubo. So just to highlight the fact that it's stepwise and it will require patience, and funds to make that actual diagnosis. But once it's done, as Dr. Fosu has said, it's basically supportive heart failure management as appropriate. Thank you.
Thank you so much, Dr. Kitty, for that great input. It's well appreciated. Okay, so going into the chat room, Dr. Oyebo is saying thank you for this concise and clear presentation. Dr. Isubi, Dr. Onelum, Neka, Charles Okuri, Mohammed, Olamiko, all of them are applauding you for a lucid, excellent, and detailed presentation. Okay, so I'm not seeing any other hand from Dr. Conte. Is that an old or new hand? Okay, so in the absence of further questions and contributions from the participants, I'll hand over the class to our chief.
Sorry, hello, Dr. Fred.
Okay. Okay.
Yeah.
Yeah. Okay.
Yeah. Thank you. Hello.
You can speak up. Thank you.
Yeah. Thank you, Chief Fosu. Yeah. Just like you said, under the pathophysiology, it's been said that the common ones is the apical, because it's said about proposed that possibly the innervation of the apical area is very rich in the sympathetic innervation. However, in about 75 to 80% in the apical, then 10 to 20 in the mid ventricle, and in rare cases, you could have the basal biventricular. And then concerning the trigger that you also talked about, of course, the commonest is the physical trigger followed by the emotion. But of course, you could have both cases in about 77.8% of cases being the cause. And then in 28.5 cases, they said there are no identifiable trigger. And also still under the pathophysiology, the proposed makes said to be unknown, that it can't be solely catecholamine. The reason being the fact that the patients with pheochromocytoma, of course, with excess catecholamine, and they rarely come down with Takotsubo. So catecholamine alone, of course, cannot be the sole factor. So they've talked about maybe other factors being responsible for it. Okay, thank you.
So thank you so much, Dr. Yudeji, for that contribution you made. Thank you, we appreciate it. Okay, so we want to call on Chiefs. I'll hand over the class to Chief Okobi. Thank you.
Thank you so much, Dr. Florence and Dr. Conte. Then we'll call on the prof is around. So Dr. Adeyanju, please over to you. Okay, Adeyanju, are you there? Okay, she's not around. Dr. Allison, please, can you make some contributions?
Yes, thank you, Chief. Good evening, Dr. Kopi. Good evening, everyone. Thank you so much, Dr. George. In fact, I should say God bless you. Thank you for this detailed presentation that you have made. It's obvious that you have really put so much into it, and I personally appreciate you. Thank you so much. So this is a very important aspect, both for subspecialty and for general medicine. So we should please go over these slides again, just to brush up. But he has touched on so many things which are quite important. But just to emphasize that, although you mentioned it at the tail end when we were talking about management and talking about when they asked a question about the normal course, but part of the definition should be that it's a transient phenomenon. Actually, it's a transient phenomenon. Then you are also required to know, just like Dr. Florence asked, the let me say normal progression, and they could ask of the prognosis. I think there was a past question recalled that talked about prognosis, which is quite important. In the prognosis, it's been said that ideally the mainstay of treatment, besides the supportive care that you give, is to remove the stressor as much as you can. Take care of the stressor. So when you remove the stressor, the catecholamine release is reduced, and ideally, the hallmark for Takotsubo cardiomyopathy is left ventricular dysfunction. So ideally, that should be reserved, and the patient could go back to normal left ventricular function while on admission. However, studies have shown that there are some that will not revert until about 2.5 weeks, even up to 12 months before the heart function goes back to normal. So we should take note of that. So the first thing, we take care of the stressor as much as we can, then give the supportive care. So managing the stressor is an important part of the management of Takotsubo. And also part of the criteria, the Mayo Clinic criteria, which I think in my brain is the commonly used. Also, you need to exclude hypertrophic cardiomyopathy as part of the criteria, because you rightly mentioned that some variants could actually present with left ventricular full tract obstruction as well as systolic anterior motion of the mitral valve. So you must actually rule out hypertrophic cardiomyopathy before you make a diagnosis of strictly Takotsubo. And in the pathophysiology, yes, studies have shown that really can't say it's only catecholamine release. There are other theories too that have been proposed that could be a cause from the neuronal pathway even to some people talk of vasospasms, some talk of microcirculation and abnormality, which was I appreciated what Dr. Eugene, I think, mentioned about Minoka. It's very, very important. And Takotsubo cardiomyopathy is just a type, a subtype of myocardial infarction of non-obstructive coronary artery. So we should take note of that. And other pathophysiologies too would play a part in Takotsubo cardiomyopathy. And lastly, when you talked about ECG abnormalities, we should know that not only T wave inversion, segment elevation is not only that. Arrhythmias ranging from atrial fibrillation, ventricular tachycardia, and ultimately to start the point are important to note because the patient can go into ventricular tachycardia and die for life at the acute stage. So you should please not miss out VT, TOSAD, as well as atrial fibrillation. By and large, it was a very brilliant presentation. Thank you so much.
Thank you so much, Dr. Allison, for that brilliant contribution. I don't know if Adeyanju is around before we move to Prof. Dr. Cyril, are you around? Dr. Cyril is okay. Okay, I don't think he's around. Okay. Hello, Prof. Please, over to you, sir, for your council contribution and direction. Thank you so much.
Okay, great presentation, Dr. George. So one quick one. Dr. Akeredolu Grace, I salute you, man. Okay, so one quick one is that Takotsubo cardiomyopathy is very... Yeah, God bless you. Good to hear your voice. So Takotsubo cardiomyopathy is a question that is very common in MCQs. And when it comes out in the BIVA, they would present an ECG. They will just give you a good clinical scenario, present an ECG that would look like ST elevation MI. They would give you in the history that the patient had I think what you come out is that the question will be stepwise question. So when they give you a clinical scenario of typical age, typical clinical presentation, and with the ECG, they will present the ECG before you. They will ask you what are your differentials. You will state the differentials. Then they can now proceed that what is the next investigation you will do. And when you say, oh, you're going to do an angiogram and all that. So they will now add that what if the angiogram comes out normal? What will be your diagnosis? What other investigations will you do? And how will you manage? So I think that is how the question will come out in the OSCE station. So I want you to prepare your mind that because in our own time, questions came out as a stepwise question, step ladder question. So not all the questions were asked in the scenario. There's a area of the scenario when we give some responses, they will now further ask more questions or add more information. And we now respond to the questions after those new informations and things like that. So it will be step-by-step questions. So it is very examinogenic. It can come out in MCQ or in the OSCE. So great presentation. It will be good we review the slides. Thank you.
Thank you so much, Prof. Thank you so much for always being around. Thank you so much, Dr. George of Fosu, for the brilliant presentation. I'm so sorry, I was a little bit distracted during the presentation. I'm not sure if you spoke about the role of cognitive behavioral therapy in your management and biomarkers like COMT gene. I don't know if you spoke about it, Dr. George.
No, please, I didn't.
Oh, okay. I think recent direction for management, in addition to what you said, is the CBT and also the place of and biomarkers like the catechol or methyltransferase enzyme, which is involved in metabolism of catecholamines. They've actually found out that the COMT enzyme also regulates mood disorders and some other stress level. So with Takotsubo Cardiomyopathy, they found out that COMT gene expression or biomarker has been quite expressed, and that's also one line of direction in terms of diagnosis and management. So there's now the role of psychological intervention, such as CBT, reducing stress and improving the outcome in Takotsubo Cardiomyopathy. But by and large, I want to say very big thank you. Thank you for stepping up to take the topic and doing justice to it. I'm very sure that those going for exam and others will find this very useful. Please, just as Prof said, if you can put the slide up on the page so that we can review it, especially those going for exam. And if you can help check the COMT gene and other biomarkers. I think there are some, even though DNP and others are not too specific, there are some other specific biomarkers we're actually investigating towards Takotsubo. And then the role of CBT. Probably if you can just add that and make it available. By and large, thank you so much for the effort. Thank you. It's a brilliant presentation. In the absence of any other contribution from anyone, I'll hand over the class back to Florence for the next phase of the discussions. Thank you so much.
Okay, thank you so much, Chief. Thank you so much, senior colleagues, for your contributions. They made a great impact on us. Thank you once more, Dr. George Ofosu. Thumbs up to you. We well appreciate it. Thank you. Okay, so we'll move over to the